welcome to the fifth program of this year of the Excelsior Educational Program. This evening, we have the really honor of having the director of our pathology department, a friend, an old friend of mine, Dr. Zhang. He's going to talk about urine and bladder pathology for PCP. Well, I know Dr. Zhang probably longer than anyone else. And last time, Dr. Leibowitz introduced me, and he met me when I was a fellow at Mount Sinai. I met Dr. Zhang when I was a medical student at Mount Sinai. That's how far back. And I was doing a research in microbiology with the world-renowned, the late Dr. Edward Baton, and Dr. Zhang was there doing a postdoc and was helping out in the lab. And we met each other and we admire each other's research effort. And over the years, we stayed connected. And I was very happy when I joined Excelsior that I saw him there. And this is really a long time coming for me to work with Dr. Zhang. Dr. Zhang did his medical school and master degree in China, Norman Bethune University. And he went on to do his PhD at NYU School of Medicine, and also an MPH at Mount Sinai School of Medicine. And I think that was the time that I met him. And it's really an honor to have him this evening to talk about a very important topic for all the internists and specialists. David.
Hi, everyone. Can you hear me? Can you hear me?
Yeah, we can hear you.
Oh,
yes.
Okay.
Yes.
Great. Oh, okay, great. Thank you. Thanks, Dr. Kuhn, for your very nice introduction. You know, our relation, both academic and the friendship, go back way back, long time ago. 25, 30 years old already. So I'm so happy you joined Excelsior. We're can have opportunity to work together. That's really fantastic. So today I'm going to just talk about the bladder cancer screening and diagnosis, mainly for the PCP who is taking care of patient regularly, and how to handle the bladder cancer screening, and what in the laboratory we can offer. I'm going to do the next one. Let me see how to lock screens.
Screen share.
No, can you see my screen?
No.
You can't see. Oh, okay. Let me just do one more thing. Okay, I had to share one more time. Okay, sorry about that. Can you see it? Okay.
Yeah, got it.
Okay, good. So let me see. Can I move to the next screen? Next one. Okay. So cancer screening, it's very important in terms for disease prevention, and also most important to save the patient. If we screen patient found early, and we can save the patient, and also would reduce the poor consequence and the mortality, and also reduce the burden to the community in terms of cost. Bladder cancer, you can see that this is I think 2021, and you can see that the leading cancer, bladder cancer, ranked number 4. In male, it's about 60% of all cancer new cases in the bladder cancer, and of course in the female, the bladder cancer is way too low to be listed on this top 10. And in terms of deaths, bladder cancer ranked at number 8, at about 4% all cancer deaths in male attributed to the bladder cancer. Bladder cancer, therefore, you can see from the instance and from the death, they all ranked very high, top 10. But in female, it's relatively lower and not even enter into the top 10 cancer incidence and death. So you can see that the bladder cancer is primarily should be focused on the male population and to identify the early stage of the cancer. Yeah. What is the risk factor for the bladder cancer, including the smoking? And usually smokers increase the bladder cancer risk 2 to 6-fold compared with those who do not smoke. Attribution risk can be as high as 80%. So what that means is that between 50–80% of the bladder cancer due to the smoking, so it's very high. And also occupational exposure is very high, including aromatic chemicals, rubbers, leather, paint, dyes, petroleums, arsenic, and the list actually very, very long. There's also parasites, schistosomiasis. This can cause a squamous cancer of the bladder. And as we will see later, bladder cancer squamous components is very, very low. But in the schistosomiasis is primarily squamous cell carcinoma. And this is actually the board type of question always asked. And also the drugs, some drugs can cause bladder cancer, chronic irritation, including stones. However, a good number of patients have no risk factors. So if you only based on risk factors screening, you may miss out some cancer. Cancer, as other cancer, can be divided by the stage. Okay, and so there's bladder cancer has been changed dramatically in terms of staging and also the grading of the cancer. You can see that nowadays we only grading the low grade versus high grade. This is WHO 2004, so that's the grading system we use. And on top of the slide, you can see there's a progression of the bladder cancer. There's two types of bladder cancer. One is grow into the lumen, so that's a TA and T1. And then there's a bladder cancer goes through the deep, okay, and that T2A and T2B, and then you further go down the road of the invasion. So most of the bladder cancer is in the TA and T1 stage, which is growing into the lumen, and which can be easily seen and also can be identified on the cytology. The very important is that why we want to identify the bladder cancer in early stage is just because the survival. And in the TA or TIS in situ, and you can see that over 90% of people would have a 5-year survival. And if you go down to the stage, which is invading into the deep muscle, and by reach to the cirrhosis of the bladder, and which is stage 4 disease, and then the 5-year survival is only 10%. So luckily, a majority of patients, when we identified the bladder cancer, if we go through the screening, they are either in the stage 0 or stage 1. Okay, and so therefore, bladder cancer is one of the cancer we can screen in early stage, identify the disease in early stage, and manage patient appropriately, and patient have long-term survival. And similar as cervical cancer and breast cancer, right? Bladder cancer, as I mentioned earlier, there's two morphology. One is a papillary, grow into the lumen, and the other one is a flat, more invading in deeply. And so most of bladder cancer is actually papillary lesions, and a small percentage, 20 to 30%, actually flat lesion and grow more likely invading into deep muscle and cause metastasis. So a papillary usually start from a papillary hyperplasia or papilloma, then going to the panlum, a low-grade uricilial carcinoma, papillary uricilial carcinoma. And this low-grade papillary uricilial carcinoma often recur, even you remove it, it come back. But that's why the patient need constant monitoring. And then subset of the patient that would go into the papillary high-grade lesion, and then small percentage will go into the invasion. On the other hand, it's the flat one, majority of them going to the invasion, and 50% going to the metastasis. So the flat lesions more likely to be invasive, and the papillary more likely to grow locally. So that's the difference of these two morphology. Urothelial carcinoma, primarily bladder cancer, constitutes about 90 to 95% of the bladder cancer, and the small percentage of included 3% or 2% of the squamous carcinoma and the glandular neoplasm, and this is predominantly caused by the schistosomiasis, and also there's some urothelial carcinoma can have a significant component of squamous carcinoma components, and this is just shows the different morphology of the bladder cancer. I don't want to bore you on that. So what's the sign and the symptoms clinically? Mostly, and as we learn in the medical school and in the take the board exam, it always said the bladder cancer is a painless gross hematuria. Okay, and which present about 80 to 90% of patients, and this is classic presentation. And why patients have this hematuria? And we can go back to this picture. And because this is papillary lesions, so that this papillary, when they grow big enough, usually they sloughed out from the surface of the bladder. So in this papillary core, there's a blood vessel. So because of the slough out of this papillary, so that's why you have a bleeding into the bladder. So this is a papillary lesion usually have present as a bleeding. However, the flat lesion going down deep and usually do not present as bleeding, or hematuria. So that's we need to pay attention of the percentage. So some patients may have a bladder cancer, but they never had a gross urea because hematuria, because the different growth pattern of the tumor. And on the other hand, those who do not have a hematuria and what we call the flat lesion or deep invading lesions, and they usually have a irritating bladder syndrome, and so have dysuria, urgency, frequent urination, and which has happened about 20-30%, and most commonly occurred in those who has deep invasion. So we be aware of this kind of a bladder irritative symptoms. And also, once you have the local invasion, then you're going to have the pelvic bone pain and the lower leg edema, because affecting blood circulation. And when you invading the back, it can cause the low back pain. Okay, and then when you have a big mass, then you can be palpate. So in terms of screening and diagnosis of blood cancer, primarily you do the urine analysis at microscope, and once patient have the microscopic or mostly gross hematuria, and then next step you need to look into the cytology, and the cytology, it's a gold standard methodology to screen and the diagnosis of bladder cancer. Okay, and which is offers a non-invasive methodology that can help. Most importantly, when you send to the lab, you make sure you have more than 30 ml of the urine. Most people only take like a 10 ml, like you doing the urine microscopic urine analysis. That's not enough. You need more than 30 ml to increase the number of urothelial cells in the sample, so that we can identify the cells. which has malignant features. So the have enough urine volume is very important, and which can help improve the sensitivity to identify the tumor. And also there's urine cytology is more important to identify the tumor in early stage, and so patient can be treated and managed appropriately. And next stage, when you identify, we identify the repetitively atypical cells or urothelial carcinoma. The next step is sending to the urologist to do the cystoscope. Yeah. So in terms of urine cytology and when you should do the urine cytology, then if a patient have hematuria or have irritative voiding symptoms, then you should do it, because hematuria usually identifies presenting in those who has a papillary lesion, and the irritating voiding symptoms usually presenting in the more invasive type of bladder cancer. And and this is also the initial workup even for urologists for the suspected urothelial carcinoma. Okay, and also for the surveillance, if the patient identified has low-grade urothelial carcinoma and the urine cytology is very common. So who should be screened for the bladder cancer? Of course, those who has a hematuria, and especially persistent hematuria. Okay, and also with the high risk of bladder cancer, those who has older, 65 years old, and a male patient, smoker, occupational exposure, and this is the high risk group, and those who has unexplained the irritative urinary symptoms, and those who has been treated and still have symptoms, and that you should have a test, do the cytology, and that potentially is due to the urothelial carcinoma in situ or flat lesion, as we said. Okay, so that's the like the population of the patient that you should submit for the urine cytology test. Of course, when you have the diagnosis of urinary bladder cancer, then you should follow up with the patient, and it usually can be followed up by primary care doctor or follow up by the urologist, and of course, including urine analysis, urine cytology, and fluorescence in situ hepatitis. I'm going to talk a little bit about that. And there's also some tumor markers can be used. And however, all these tumor markers not pan out to be very, very useful clinical setting. So still the primary screening or surveillance method is the urine analysis and the urine cytology. So urine cytology has been evolved into multiple stage, and currently being recommended is the Paris system reporting urine cytology, which is published in 2016. Okay, and so the category they defined as 7 categories in the diagnosis. And so in my report, you will see this. If you look at the urine cytology quite a lot, and you will see my report divided into these 7 categories. And the first category is non-diagnostic and unsatisfactory. Basically, you don't have urothelial cells in the sample, so which is not enough. And then majority of the patient, I call them a negative for high-grade urothelial carcinoma. And then there's a small percentage of atypical. And then next category is suspicious, and then low-grade, high-grade. And so this is how I grading them into the different categories. Okay, it is very important for you to know each category, because each category carries a different risk of malignancy and how should be managed differently. Okay, the first category is unsatisfactory or non-diagnostic. And in this category, the risk is not well defined, probably less than 5% risk to have malignancy. And this is mostly due to the not enough urine volume. Okay, and so in these categories, and you should repeat cytology. Okay, or if clinically suspicious, you do the cystoscope in 3 months. So mostly repeated cytology, and that will usually recommendations is 3 urine cytology consecutively. So if that's completely negative, even patient have symptoms, and probably the chance to have a urothelial carcinoma relatively low. Okay, and in the negative categories, and you can see they still have a 0 to 10% risk to have malignancy, and this is just because that the urine, the urothelial carcinoma slough out into the urine at a low number. So if you just do 1 urine screening, you may not have the lesional cells in the urine to be able to identify by the pathologist. So in this case, you have to continue follow-up. If the patient have the risk factors, you should continue follow-up on the patient. If the patient have a typical urothelial cells in the report, when I reported, and that means the patient have the risk of 8 to 35% of the chance patient have malignancies. And so this patient you should need to watch more closely, and we also can apply some ancillary tests to identify those patients who has malignancies in the bladder. Next category is the suspicious for high-grade urothelial cell. If you lump in if you call the high suspicious, the chances of between 50 to 90% of patients have malignancies, and in this case, definitely you need aggressive follow-up. You need a cystoscope and a biopsy to confirm. So at this point, I would suggest go ahead and refer to the urologist, let them to taking care of the patient. Okay, and so the high-grade urothelial carcinoma, and it's just diagnostic. So basically, you just straight refer to urologist, have them take care. So for the primary care doctors, usually this is 3 categories you need to pay attention. One is the unsatisfactory, and then that's saying you need to resubmit the urine to make sure they have a large volume. And then next one, it's negative. You should, if patient has a risk factor, you should continue monitor. And if a typical urothelial cell, you should continue monitor patient and to see if there's a diagnostic cells present. The pathology can call it either benign or malignant. And once it reach to the suspicious or high grade, and you should just go ahead to refer. Okay, and there's a number of biomarkers can be used for bladder cancer diagnosis, and usually we commonly use it's the Eurovision, and this one you can see that the sensitivity of the cytology is between 30 to 90%. Usually it's very good for high grade lesion, and if the low grade lesion, the sensitivity of the urine cytology is extremely low, and the specificity is very good. When you call it pathology called the high grade urothelial carcinoma, it is basically diagnostic. Okay, and the Eurovision, it's usually helps to the category of a typical or suspicious category, and in that category, the sensitivity can be bumped up by this test in combination of the cytology. There's also other tests being used, but it's usually not very widely accepted. And here basically you can see the study was done in 2000 by a group of urologists and pathologists at Mayo Clinic, and you can see that the combination of the cytology and the FISH can be increased, both sensitivity and specificity significantly improved. So that's why, and often when we have a typical or suspicious, and I suggest to do the FISH test. Now, so when you receive the cytology and the FISH report, what are you going to do with this report? Okay, and so this is probably take home the message for the primary care doctor. And if a cytology is negative and a FISH negative, and you just do routine follow-up. Okay, and the likelihood of the breast cancer, the bladder cancer, it's only low. It's about 5%. Okay, and then if the cytology negative, fish is positive, and then you need a more close follow-up, or even do the cystoscope and refer to the urologist. And if a cytology positive, fish is negative, and then you should go ahead and do the cystoscope. And if the cytology is a positive, fish positive, and it's cancer, to prove otherwise, okay? And in this situation, you should just go ahead and refer to urologist. So this is actually what I prepared for this talk, and I was told only for 30 minutes, and then rest for leave for the discussion. So I published this book, and in 2 years ago, and which is focused on the bladder and prostate biopsy pathology. And but I also made this book available online. So if anyone interested to know more about the bladder cancer and prostate cancer, and you can go into this online book, which is basically moved to this paper version book to the online, and you can look at this anytime you want. So basically, yeah, so if you click this one, and that's bring to my website, and which have a number of books published here, and you know, so you can enjoy what after you have a dinner. So I'll stop here and take some question. I think exactly 26 minutes. Perfect.
Thank you very much, David, for a very, very informative talk. So now the forum is open to the listener. Anyone who has any burning question for Dr. Zhang on this very important and timely topic?
Hi, this is George. Dr. Zhang, you had a great talk today. I have two questions. Maybe I didn't listen clearly.
Okay.
One is we need 3 samples continuously, 3 days sample to be sure the sample is negative.
Yes, 3 samples is what have most some of the urologists practicing, and basically you take the you know, like either 3 consecutive days, or you can take several other days, you know, like 2 or 3 days later and take. The reason is that because the shading of the tumor, especially early stage tumor in the urine, is very low frequency. So you need to screen more times in order to identify the diagnostic cells, right? So some urologists basically do is that they give the they take one urine sample in the office and give patient 2 vials, and patient go home, take 2 additional samples and bring to the office. So they don't have to come to the office on every day. So patient can just collect the urine at home and bring to the office. And some urologists basically collecting the urine, first urine, and have a patient come back 2 weeks or 1 month, collect another one, and come back another month and weeks, and then collecting third one. Okay, so if consecutively third one is negative, and the chances are you miss the bladder cancer, the chances are relatively low. Unless patient still have the symptoms and also have the hematuria, need a more frequent follow-up on that. I'm not sure if I answer your question.
Very good. Another one is the sample volume. We need to use the big cup or the specific sample cup.
Yeah, I would suggest use a bigger cup, because a big cup you can collect more. So as I said, the minimally 30 ml of the urine you need to get enough volume to identify the rare tumor cells in the urine, right? So the more the better, of course. And you know, most people when doing that, they collect the urine, they have the urine sit in the room for until the evening, right, before you leave, and then you put together. And what they do, they pour the top and give for other tests and for the urine cytology, and leave the bottom one for the urine analysis. Actually, that's not good. And the good thing is that because the cells are precipitated on the bottom of the vial, if you let the seed down there, the good material actually on the bottom. So you want to give the button to the cytology to do analysis. So I would suggest you just do collecting the large vial, at least 30 ml, 50 ml, even better, even 90 ml, even better, right? Large container and send to the lab, and the lab would do the urine analysis for you, and the remaining, the lab would do the cytology.
Okay.
David, I just wonder, just a quick question. Is diet going to play a role in bladder cancer, like the thing that we drink, coffee, soda, and alcohol? Any one of these have been shown to cause increased risk of bladder cancer?
Well, in terms of food, and there's no study has demonstrated kind of have a strong association with bladder cancer. And there's some study shows that if you drink teas, then it can actually reduce bladder cancer. And in fact, in China, and they did a study compared with the people drink tea a lot, people don't drink tea a lot, and it seems to be people drink tea a lot and reduce cancer risk. Right. So, but this study hasn't been, duplicated. And, but we know that if you quit smoke, you will reduce, 50 to 80% of time of the chance you're going to get a cancer. So quit smoke is very, very important. Of course, the occupational exposures are another very big sectors. And petroleum, for example, the people working in the gas station, and the car, like the mechanics, and they have a lot of exposures, and these people should be screened more often, right? And because they're high risk for bladder cancer. But the food itself, there's no study has shown coffee has a link to the bladder cancer, and even alcohol, and more often because people drink alcohol and also smoke. So that's kind of synergistic effect cause bladder cancer, but just alcohol in itself, and it's a very low risk to the bladder cancer.
What about the Western diet, the processed food, and you think that give you a higher risk?
No, actually, like the study has shows that the Western food, like the red meat, right? It's more associated with colon cancer, and then not much association with bladder cancer. So same as lung cancer. Lung cancer is predominantly as a smoker, right? And the dietary usually have a less influence on the lung cancer, similar as the as bladder, because the carcinogen from the cigarette smoke, there's about 300, but 100 of the WHO defined class A carcinogen, right? And but this carcinogen can cause lung cancer and also cause bladder cancer. So they're the same etiology, and so they both have not much to do with the food.
Mm-hmm. Any other questions?
David, I have a last question. Is Pathology, just like the other lab, for the insurance, you accept, or for you can accept every insurance?
Well, urine cytology, it's a pathology test, and some insurance do pay us, some insurance don't pay us. But I think that like the list I sent to you to each clinic for the insurance, like even the house first who do not pay our laboratory test, but would pay the pathology and cytology. So majority insurance would pay that, include the house first and Fidelis and WellCare, UHC, and BSBC, and all these major insurance would pay cytology. So.
Okay, because this is different from the usual lab. Can you send us a list of the just for cytology? We can tell them that one maybe more clear for everybody.
Oh, yeah. Okay, I will do that. But just remember, urine cytology actually cost is very low. It's basically cost my time to read the slides, right? So it's not like if you do the blood test, if you don't pay us, we spend like $10 for the CBC, just just the reagent cost, right? So the cost is very low. So even they don't pay us, we still be fine. You know, we don't lose a lot of money. And also the second factor is that if we don't accept the insurance, I usually send to the other laboratory to do the test. And because you know, so in this we don't cost the single dollar. So you just send to us, and we in the lab we figured out which one we take, which one we don't take. So you don't have to bother with that. Just send the urine cytology to us, all of them, and we figure it out from our end.
Okay, good. Thank you very much, David.
Yeah, thank you, George.
Thank you.
Any other questions?
I have a quick question. So does the
Lisa.
freshness, does the freshness of the urine affect the yield of or sensitivity of detecting those pathological cells?
Well, this is a very, very good question. Okay, you know, different urine, right, have a different purpose, and you know, like for example, usually when we do the culture, we use midstream because the first stream and have a lot of bacterial contamination, right? So for culture, midstream, it's good. And for the chlamydia, gonorrhea, which we also do in our laboratory for the urine from urine, and that's usually the first stream is better. Why? Because the gonorrhea, chlamydia, usually it's the urethra infection, right? So the first stream that carries more bacteria, so it increase the sensitivity detection. And for the bladder cancer, and actually, you know, we collect the entire stream, the first, the second, and last stream. Okay, so that's the different stream. Now, in terms of what would be the best in the morning urine, or after urine, or evening urine, which one urine is better? Okay, from cytology point of view, actually the first urine in the morning actually is better. The reason is that because the cell sloughed in the urinary bladder for a whole night, so you don't pee them out until next morning, right? So that urine actually is good for the cytology. Okay, and once patient drink a lot of water and pee very oftenly, and that reduce their sensitivity, and so that's why some urologists give the cup to the patient and tell patient the first morning urine you pee into this cup. Okay, so that increased the sensitivity. So I would suggest, you know, the patient, you know, the first urine in the morning for the cytology would be the best.
Thank you. That makes total sense. Thank you so much.
David, can I ask you a question?
I'm waiting for your question. I know you always have questions.
Nah, you're the boss today. Does it, with things like acidic or basic urine, make a difference in the way the cells look? And in addition, you know, like when you do a pap smear, sometimes the woman will have like a trick or another infection that turns the pap positive, but you treat the infection and you redo the pap and it looks okay. Is it similar for this? So question A, acid base in the urine and the way the cells look to you. And the second question is, if there's either bacterial contamination or a UTI, does that affect what you're seeing?
Yeah. Okay, this is a very good question. You know, bladder actually, it's because the function of the bladder is holding the urine, and this urine are very toxic. It's because at the end of the anything bad stuff you excrete into the urine and hold in your bladder for a while, right? So that's why bladder, if you have like a smoker, you have a lot of carcinogen there, it can cause the bladder cancer because the cylinder is too long. Okay, and however, the bladder cells, right, it's actually designed to resist to the urine. Otherwise, the bladder will be a problem, right? The urine going to be leaking into the bladder wall. So
right,
so
like the stomach is resistant to acid.
Exactly. So the cells stay in the urine. Actually, they don't degrade it that fast. So that's why you stay whole night. Next morning, you collect the urine. You still have good cells to make diagnosis. So they don't degrade it. That cell would degrade is not in the bladder, not supposedly in the bladder. For example, the macrophages and you know, like when you have a bacteria, and then it causes the bladder bleeding. and the inflammation, that cell usually don't stable because that kind of degraded very quickly because the toxic in the urine. So if the patient has the UTI, and would that have caused the cell change? Yes, they can cause, because when you have inflammation, you can cause to cell become atypia. So when you see the atypia, when I call it atypical cells, and I also mentioned in the WBCs, and in this situation, you should step back. Okay, have a patient treated and the UTI and collect the urine again. Okay, and then to see if this the atypical would disappear. And most time the atypia because of the inflammation, right? And once the inflammation be treated, and atypia would disappear. Okay, so that's actually one of the drawback for pathologists. When I see quite a lot of atypia atypia in the background of the inflammatory cells, I usually step back. Okay, and I call it, if suspicious, I step back, called atypia. Okay, so in this, trying to avoid overcalling due to the inflammation. So in this situation, when you have a patient that have a UTI or any kind of inflammation, then you should just have patient treated and collect the urine one more time.
So speaking to that, here's the question. You got a guy coming in with atypia. Now, if you have atypia, is it a permanent atypia, or it could be on Monday he has atypia, on Wednesday he doesn't have atypia, right?
Yes, yes,
right.
Correct.
So that's even without a UTI, on Monday you see atypia, on Wednesday he doesn't see atypia. If on Monday he has atypia with a UTI, and then you treat the UTI, and next Monday he's clear, are we happy? Or do we say, gee, I don't know, maybe you get a cystoscopy at that point? So does atypia really trigger it, or you're happy redoing it? What do we do?
Okay, so atypia, right? If a patient have a 3 consecutive urine and without the UTI, without the acute inflammation, right? And that one you should really be, sent to the urologist, to consider it more aggressive, invasive diagnostic procedure, right? And but we usually once atypia, right? You can do one more test. Just I said, order the urine vision fish. Okay, the fish can increase the sensitivity. So if a patient have a consecutive 3 atypia and then the fish is negative, and I would less worry. If the fish is positive and it's continue as a atypia, and I will straight send to the urologist to do the cystoscope. Okay, so that's the thing. Now, as you said, patient can have the first time it's a atypia and second time negative, and third time become a atypia again. And the reason because the tumor, it's especially small tumor, they shade in the only few cells into the urine. So this time you catch one, next time you may not catch, right? So in this situation, if a patient have a risk factor, constant persistent hematuria, especially gross hematuria, and if I have the bladder symptoms without any, infection of bacteria or WBC, and this patient, I would be more close follow up, and have patient come back to the urine test again. And also the smoker, right? Elderly patient, the smoker, male. This is the risk factor.
Thank you. I don't know how many elderly smoker males you have left, but they don't last long anyway.
Yeah, it's still in the Chinese population, we still have quite a lot.
God bless. Keep going.
Yeah, especially those like workers, right? Like my contractor, he keeps smoking, and even I told him I said smoke good, but he said, I'm just too tired every day. I need smoke. So.
Yeah. Any other questions? I know it's a lot of interesting question, and I'm sure some people missed this talk, and they can watch it on YouTube tomorrow. And feel free to write to David if you have any other questions that you're too shy to ask in public, and David will be more than happy to answer you.
Yes,
okay, thank you very much, David, for a very informative talk.
Thank you, Michael, for hosting this talk. We'll talk
Okay.
later. Okay.
Thank you.
Bye, everyone.
Bye.
Bye,
Thank
everyone.
you. Bye-bye.